So we're going to go through just some kind of more meaty stuff that you can take home with you and think about transitions of care. So I just wanted to share, just in terms of best practices, that there are 5 key areas that we like to focus on. Just a way of kind of thinking about what you need to address around a care transition. So the first is patient and or family engagement and activation. The second is medication management, like we said before. The third is having a comprehensive plan for the transition. The fourth is supporting that transition, who is doing that and who's in the support system. And the fifth is around communication around that transition. So what I'm going to do is, against what I normally do, is I have a lot of wordy slides here, and mostly I want you to have them to look at them later. But I'm going to go through typical failures that happen, nationwide, all over the place, time in and time again. And then I'm going to show you best practices in each of those 5 areas. And hopefully this will be helpful to you. So in terms of patient and caregiver engagement and activation, some typical failures. One of the big ones is that families and perhaps healthcare providers have some sort of unrealistic optimism about what it will be like when they get home, right? You're in the hospital and yeah, you're sick, but everything's being taken care of. And I don't think anyone really has a good sense of how sick they still usually are when they get home, or how much pain they probably still have when they get home, right? People get out of the hospital way earlier than they used to, right? Basically, you're alive, you're walking, you're stable, they send you home. So this is a place where we often see lots of issues in terms of activities of daily living, like can they feed themselves, bathe themselves, get around, manage their pain, right? Other issues, or I think the big one that I would pick out from here is this thing about there are so many providers, and the patient and their family or support people, I would say 99% of the time, think that there's one person in charge. They really do. They might not be able to name that person, but they think there's one person coordinating all of this. They think that their stuff is going back to the primary care office or it's going to the nursing home. They think there's someone in charge. But we know the big bad secret is that there usually is not one person in charge. So some best practices around patient-family engagement and activation. You want to, if possible, if you can meet people in the hospital, or if you're not there, hopefully someone else does this. But really, I see this as ideally a coordinator role, is to do an assessment of the patient and their family or caregiver's ability to take care of themselves and to manage post-discharge and when they get home. If you're not able to do that and you find out about this right after, hopefully you are calling and checking in with them and finding out how it is going at home, right? Like, who's calling them at home? Maybe someone from the hospital, maybe someone from primary care, maybe someone from somewhere else, but frequently not. Frequently that's a sort of dropped period, right? And again, this is the most dangerous time when people end up going back to the hospital. So the care coordination best practice here is really to work with people, as you mentioned, before they leave the hospital and with their families and their support system if they have them. Use health literacy principles like we talked about last session. Use teach back. Simple to understand materials, right? How many of those discharge materials that come into the hospital are just, the things I used to see, like Xerox forms, hand scribbled. You can't even tell what they were in the hospital for, right? So someone, and it's probably you, needs to make things clear, simple, make sure they get those kinds of instructions and things they can follow that are readable and legible and that they understand. Okay, so medication management, typical failures. Again, we're back to if there's no one person accountable for this whole scenario, then there's probably no one person accountable for their meds. Frequently in the hospital, you have, cardiology prescribes their stuff, and urology prescribes their stuff, and there's a bunch of different prescribers, and those meds may or not have been reconciled at the hospital. Interactions may or may not have been checked. And then you have what was the patient taking before, and how does it line up with what they're taking now. So again, if you can bring in a pharmacist, or if you're not a nurse and you need a nurse, right? You just want to be thinking like, I need to get someone with the clinical experience to review this and make sure that it's reconciled correctly. The other thing, and I know we mentioned it before, is that I think at a hospital it's rare that someone is assessing the resources that a patient has in terms of getting these medications, right? So is there a copay? Are they going home with the meds, or do they have to go to the pharmacy to get the meds? If so, who's going to do that? Are they well enough to go to a pharmacy? Do they have someone who can do that for them? So that's kind of part of your assessment, your post-discharge or immediately after discharge assessment. Like, actually, how are these medications going to get paid for and get to you? So best practices around medication management. Someone, whether it's you or somebody else, needs to assess their understanding and knowledge of these medications. Hopefully you include teach back. I think one of the most helpful things that you can do is create, right, a very easy to use, like, these are the meds you're taking, this is what you're taking them for, this is how often you take them, these are the side effects to expect, right? This medication makes you dizzy, that's normal. And here are the red flags, right? And then maybe that's not you, but someone needs to make that list for them in a very easy, health literate form, right? Oh boy, yeah. Yeah, go ahead.
It's so often that I was a coordinator, so often that I go into a patient's home, and even though I'm not the nurse, if they have a bunch of meds that they're taking, I ask them, do you have a second set of eyes looking at your meds weekly, or after you've set your meds? Most of them are setting their own meds, and a lot of times I just look in and I count. One white, one white, one white, one white. Oh, here's 2 whites. One yellow, one yellow, one yellow. Oh, there's no yellows in this one. And it's so common that they have put 2 in place of 1, or they have none at all in some places. Or so I think it's real important for all of them to have a second set of eyes. It could be a daughter, it could be a nurse, whoever. Somebody needs to.
But even that daughter, right? Like whose eyes are clear and she's thinking clearly. She's not 90 years old. She needs some guide, right? Like yellow pill is metformin and it's twice a day, and you know what I mean? Like she needs just clear instructions to follow. And then you're right. She could set up the pill box. Yes.
That is the biggest issue.
Huge.
What I try to do is I try to put all my clients on what's a bubble pack, so that when they're coming out of the hospital, the pharmacist connects with the pharmacist at the hospital, and the orders come in, and then it's made up. And when they come home, the meds are all ready. They peel off morning pills. They take those.
Right.
And it's so much better, and it just saves a lot of errors.
Right. So you may be the person who facilitates getting the bubble pack, right? You may be saving someone's life by getting a bubble pack.
And it's not an expense.
Yeah, no, and you don't need a license to do that. Anyone in this room could do that, yeah.
So there's even some challenges with that. You get somebody who is an AFib patient who is on Coumadin.
Yes.
You can't put, it doesn't work in a bubble pack.
That's true.
And there's confusion with, So
But it doesn't go in the bubble.
Exactly, which is why I'm saying it can be very confusing, because it's not always the same every week. It gets changed multiple times. So they still have this other pill that's not in the bubble pack that's been to figure out.
Right. Right. You still can go back to, right, like clear explanation, like bubble pack, and then this med, it looks like this, you take it this many times. Or I would say, right, that's when you need a pharmacist, a visiting nurse, like you need higher level people involved, perhaps to on the case. Yeah.
So you talk about pharmacists.
Yeah.
And they're missing from our monthly room.
Yeah.
They're missing from every conversation that I've had in the last 5 months in my role.
So I see someone here who wants to jump in.
So last fall, CVAA started a new initiative working with the Home Meds program, and it's basically a medication reconciliation program. So when someone makes a Meals on Wheels referral to us, we have a wellness benefits counselor that goes out to do a falls risk assessment, Meals on Wheels satisfaction survey, etc. And they incorporate home meds into their overall assessment process. And through that process, we gather a list of the medications, we enter it into the system that this program operates under, and if there are alerts, that gets sent to the primary care physician and to a pharmacist to review, to make sure that there are no errors, no duplications, and that's probably the closest that we can get to what you're looking for, to have that physician and pharmacist involvement.
I have a couple.
Many of us case managers at CVAA do this home meds program. If we have a current client that's discharged from the hospital, we'll go in and enter in all their meds, and then this pharmacist looks at the whole picture and then sends us an alert back saying this is counterindicated, this, the pain doesn't seem to be controlled well, check this again. And then the PCP, then we send a letter to the PCP notifying them as well of this.
Great.
We started this because we recognized that falls were sending people to the hospital, that errors with medications were happening, and we felt like it was something active that we could do with our clients to improve their overall health and situations.
So are you guys documenting all the medications and then sending it to a pharmacist?
It basically goes into a database, and it will pop out an alert if there's a concern. Then that gets reviewed by pharmacists and physicians.
It's not just meds, we do their blood pressure as well. We take their blood pressure and we ask if there's been any falls, any other significant health challenges as well.
Is that? So it's called Home Meds. It's an evidence-based program that we're part of now, the software. And so people make referrals to us specifically for that. The case managers do it. We're trying to incorporate it as best practice with all of our transitions from hospital with the Meals on Wheels referral and kind of into a whole wellness look. So it's been really helpful.
It's called Home Meds, right?
Yeah. This is the CVAA Shift About Agency on Aging. The other area agencies on aging in the state were looking at it. We've kind of been the first to get it going, and especially with seniors and other young disabled folks who then you're pulling out a whole host and history of medication, old meds in the home, right? You're inventorying and helping really to kind of take a look at what's in the home as well.
So to make a referral through that for this program is to CVAA, to the senior helpline.
Did everyone get that? Hear that? Who needs it? Okay. Yes.
Okay, so say your client goes to the doctors and there's hypertension, they go on a fluid medication, and so who catches that? Do you go back? Is it on a computer somewhere?
We can do updates.
Well, that's what I'm saying. Do they have to call you when they get new medications, or do you go up to see them every so often?
We try to reassess them periodically to see if, especially if there have been significant med changes, to catch those.
But we're not automatically alerted.
No.
that
Yeah,
a
that's
change,
what
no.
I wanted to know.
No, we're not automatically alerted. And I would say if a person has one med change, it's probably not an opportunity to do a reassessment unless there are, change in medical status, change with multiple medications.
I mean, we're not, for folks we have ongoing case management responsibilities with, and then a connection to the PCP's office, I think that's where it's really good. I think in other situations, if we don't have ongoing case management, with them, because we've done options counseling, they've met their needs and so on, new referrals can always be made and are appropriate. Part of it is we're trying to educate the PCPs as well, and those office, the practices about what we're doing. So little by little, they're becoming aware in our four-county region of what's happening.
Part of the concern is when a individual goes to multiple physicians, a specialist, their primary care office, et cetera, and each one is working individually for this individual. Through a system like what UVMC has, it's a little more collaborative because they all look at the same system and the same medical record.
Sorry, I just have a question over here.
So, first of all, you said it was somehow linked to Meals on Wheels, but could it be for someone who's not getting Meals on Wheels, like somebody who has their wife at home, they're still.
You could call the senior helpline specifically requesting assistance.
And so it's somebody who does not have VNA.
I mean, yeah, they could. Certainly, we're not gonna duplicate what DNA or AI may be doing,
Yeah.
but these assessments certainly come into play with some of our regular ongoing case management clients, and then these new referrals and any referrals that require, and it's a good way to take a look.
So sorry, just to clarify, just for the room. So it's called Home Meds. It's a free service, or it's for which kind of patients? Medicaid, Medicare?
Insurance doesn't matter.
Insurance doesn't matter. There's a number someone can call to.
Right. We serve folks who are generally 60 and older.
Okay, 60 and older.
That's our target population.
Okay.
Those are the people that we receive Meals on Wheels referrals for. And
Okay.
for us, that's one of our tools in our system. You get a Meals on Wheels referral, we want to do this.
You get some sort of alert. Okay, great. Yes.
But there are a lot of free programs out there that'll do drug interactions for you. You just plug in the medication and it'll give you warnings and stuff like that. But pharmacists are mandated too. The big thing is please use one pharmacy, because if they're polypharmacing it,
Right.
then you're in deep doo because
Right.
nobody knows what's going on. So the biggest thing you can do is make sure that you use one pharmacy.
Right.
Because they're mandated as well.
Right.
There's a mandate out there for
Yes.
them to report to the VCC any interactions they see. So there's that piece too, but you can get the free software.
Right. And
I
I just.
want to say, because I've done a little bit of work with pharmacists, that there's a national movement to get them from behind the counter to do more education. So I think it's actually a good opportunity right now for individual organizations to reach out and try to establish a partnership, because you might actually get a really positive response.
Right. I was going to say the exact same thing. This is why we work together. Which is, you have an opportunity in your role to advocate with your leadership, your docs, your nursing supervisors, whoever, to invite the local pharmacist or pharmacists, over to your clinic, or to go and take a field trip and visit them and introduce yourselves. I mean, it sounds small town, but hey, here we are in Vermont, and relationships is where it's at, right? And if you have a good pharmacist who you know and you can call and they know who to call on your end, a lot of duplication work can be cut out, and that's a great resource. So yes, we're bringing the pharmacists into the care team. They should be part of the team. Yeah?
In-house, right? And does anybody else have that sort of a setup in their practice, whatever program?
We just hired one 2 weeks ago, so it's just starting. But
You just hired a...
pharmacist to work in the primary care clinic.
Great. There we go. Look at that. Okay. I'm going to keep going so I can get you out for lunch. Great discussion. So let's talk a little bit about typical failures around comprehensive discharge planning. So we said that it's exceedingly common for people to get discharge instructions that are confusing, contradictory, hard to understand. There's often a lack of an emergency plan. Does everyone know what I mean by that? What's an emergency plan when you leave the hospital? Yeah, like if I have a problem, who is the one person that I'm supposed to call and what is their number? Not like that I have 10 organizations, but like in that a moment of emergency, right, when you're bleeding or you're in terrible pain or you've collapsed, like besides 911, who are you supposed to call, right? So that is essential, the emergency plan. And what are, do they know what red flags are and when are they supposed to call? What are they supposed to call about? And someone mentioned this before, DME. So what equipment do they need? The hospital maybe has taken care of that, maybe not, right? Does something have to be ordered? Do we know how that's getting paid for? How's it getting to their house? These are details that are very important that a care coordinator should be looking at and making sure that all of this was taken care of. So comprehensive discharge planning best practices, right? Work with the patient and the family before they leave the hospital. Help them prepare to understand what it will be like and what they should be thinking about. A high-quality discharge plan, I've mentioned this a couple times, written in plain language. You can do this. Everyone in this room can write one of these, a plain language discharge plan, right? Why were they hospitalized? It seems crazy, but like I said, people often do not know. You were in the hospital because you had a heart attack. They kept you there because you had a urinary tract infection, whatever it is, right? The medications they are taking when they get home, how to take care of themselves when they get home, what are they supposed to eat or not eat, what are they supposed to do or not do in plain language, supplies and where they're getting them, or how they're getting, or if they're already going to be at their house, what symptoms they should call for, what appointments they will have for follow-up, right? Monday at 5 is your primary care appointment. Tuesday, I will call you, right? Simple language, dates and times. And any community resources that they may be using. Meals on Wheels, a home health aide is coming, right? You guys can make these plain language plans. So transition care support, typical failures. I think the big one I would pull out of here is that bullet number 3, follow-up is seen as the sole responsibility of the patient. And here's where we really do people in, right? You're sick, you had surgery, you had a heart attack, you're in pain. You really, none of us can in these kinds of circumstances, do a good job at coordinating our follow-up care. We're not well enough to do that, right? So we need someone to help us do that. I'm hoping that's the care coordinator working with all these different entities. So some best practices around transition care support. Assess the patient's understanding of the discharge plan by asking them, right, teach back to explain in their own language what the plan looks like. If one person hasn't been designated as the person responsible, either designate yourself or designate someone else, right? So the patient knows who is that one person who's coordinating everything, who I can call, who I can get information from. So transition communication, some typical failures. So I think most of this falls into that no one person looked at the big picture transition plan to see, was it complete, was it understandable, did it make sense to the patient and their family, and also that no one checked. Did the records get from the hospital to all the various places they need to get, right? So they're following up with mental health. Did they get the updated plan? Will they know what happened in the hospital? Will the PCP? Will the nursing facility? Everyone needs updates to the plan and the most recent medical records. Okay, so transition communications best practices. So I'll say it one more time. You're probably sick of hearing it. One point of contact. One point of contact. Also, part of every care plan, and that includes a discharge plan from a hospital, is again about what the patient wants. What are their wishes and preferences? If someone has been in the hospital, particularly an unplanned hospitalization, then there is a good chance that they are not well and that they may be back in the hospital, or that they are dying, or something else, not good is going on. And so it's important that things like, who's their healthcare proxy? Do they have a living will? Next, if they ended up back in the hospital, would they want to be intubated, right? These are things that we want in our plan. We want to have these discussions. If you're not having the discussion, then link them up with someone who can have this discussion, right? There's a good chance they'll be back in the hospital. Find out now what their wishes are for next time, right? Do they want a DNR? Did someone fill that out? Where is it? Where can we find it? Okay. So that's it for my transitions of care. We're going to take lunch until 1 o'clock, and then we will see you back here.